A very good afternoon and a warm welcome to all the respected doctors who have joined us this afternoon for yet another session in the series of NEFFRON, which is an educational initiative by Saffron Formulations that involves the expert in the field of nephrology to share their expertise and clinical thoughts on the management of CKD. So today we have with us the clinical expert for the day, who is a young and dynamic nephrologist, Dr. Mital Parikh. Dr. Mital Parikh is a consultant nephrologist. He's an assistant professor, Department of Medicine, Dheeraj Hospital, Sumandi Vidyapeeth in Baroda, Gujarat. He's a diplomat, National Board of Nephrology, Mulji Bhai Patel Urological Hospital, Nadiad, Gujarat. He has many research and publications under his name in the national and international journals, and he has also presented many posters at the international and the national forums. He has also a book chapter under his name and has participated in various workshops. So, with this, I would now like to welcome Dr. Mital Parikh to address the doctors who have joined us today on a very important topic, that is the need of alpha ketoanalogue in CKD, which is an emerging topic, and there is a lot of debate going about this topic in the physicians as well as in the nephrologist forum. So, I would like to welcome Sir now. Thank you.
Thank you for the introduction. So, as you already briefed about topic, the role of alpha ketoanalogues in patients with chronic kidney disease. This is actually a very interesting topic because a lot of debate has been going on about whether to use it or not to use it, when to initiate this analogs in with what kind of CKD patients at what stage of CKD. So, in the coming 10-15 minutes, we'll discuss about everything. So, let's start with need of alpha ketoanalogue in the management of chronic kidney disease. As we all know, there is a huge burden of CKD patients worldwide as well as in India. India is a diabetic capital, and most of our kidney patients have underlying diabetes as their underlying etiology. So, if you look globally as well as in India, there is a high prevalence of chronic kidney disease patients, and it's increasing day by day. So, obviously, there has to be something which can either retard the progression of chronic kidney disease or may even halt the progression. Multiple drugs, multiple medicines, and multiple approaches have been tried. One of them is alpha ketoanalogues. If you look at the etiologies of chronic kidney disease patients, most common etiology is diabetes, which is followed by hypertension. And rest of all, glomerulonephritis, immunological disorders, some hereditary conditions, all of them have backseat for the etiology. There are 5 stages of chronic kidney disease, as we all know. As the glomerular filtration rate declines, that is the GFR declines, the stage of CKD advances, and once the patient reaches the stage 5, that is chronic kidney disease stage 5, the GFR falls below 15, and then patient would require initiation of renal replacement therapy, either in the form of dialysis, whether it's hemodialysis or peritoneal dialysis, or in the form of kidney transplantation. Now, what happens in chronic kidney disease patients is that there is accumulation of waste products, mainly it's urea, creatinine, uric acid, other nitrogenous waste products. Because there is decreased excretion, because of decreased excretory function of the kidneys, this metabolic waste products cannot be excreted in the urine and they will accumulate in the blood. Other metabolic parameters like metabolic acidosis, hyperkalemia, hypophosphatemia, hypocalcemia, vitamin D deficiency, anemia, all of this complete the metabolic picture of chronic kidney disease patients. So once this nitrogenous waste products get accumulated in the body, the symptoms of uremia start to manifest, and that is the time when we need to start the dialysis. So what are the present challenges in management of chronic kidney disease patient is that there is very few drugs which can delay the progression or delay the need for dialysis in this patient. And once the patient reaches the need for dialysis, there is no turning back. So any drug or any medicine which can prevent at early stage will be definitely helpful to prevent the progression of chronic kidney disease patient. One of the very long dated topic which is still in discussion is what is the benefit of low protein diets. So the main advantage, or I would say theoretical advantage with low protein diet, is that there will be decrease in the dietary protein content, which will reduce the protein load on the kidneys. And so this will reduce the overall nausea, anorexia, vomiting, and if it is initiated early, that is, the restriction of dietary protein intake is initiated early, it may even help to retard the progression of chronic kidney disease patient. Why this is important is because it's not only the low protein diet, but it's supplementation with essential amino acids or essential keto acids, which will help to utilize the urea as a source of non-essential nitrogen. Some other benefits like reduction of workload on the kidneys, prevention of acceleration of kidney damage, prevention of renal osteodystrophy, calcifications, and all those things. And thereby, the ultimate goal of this, any form of therapy which we apply in CKD patient, is to prevent or retard the progression. So, next slide, please. So, as I already told, goal of treatment is, the ultimate goal is prevent the progression or retard the progression. Yes, next. So keto analogs, they are the analogs of essential amino acids. They are basically helping in conversion of this keto analogs into the essential amino acids with the help of transaminases, especially like leucine. Some of the keto analogs also have supplemented with essential amino acids like lysine, threonine, which are very essential for body. Next. This we already discussed. So how does they help? Transamination will help in conversion of this keto analogs or keto acids into the essential amino acids. And some of them are also supplemented with essential amino acids like lysine, threonine, and etc., which will be a supplemental for the body need. If we look at the mechanism of action, because the dietary protein which is taken, it will help some amount of urea and nitrogen which will be generated because of catabolism. Now, this non-utilized urea and nitrogen will be utilized by the keto amino acid with the help of trans amino acids in conversion to essential amino acids. And this will help in overall body build and reduction of the protein load or the urea load on the kidney. Next. Next. So if we look at the various bodies and various organizations which are working in this field, like National Kidney Foundations, the KEDO, that is Kidney Disease Outcomes Quality Initiative, all of them have given recommendations that for non-dialysis patients, those whose GFI is below 25, that is in stage 4 and stage 5 CKD, proteins of 0.6 grams per kg body weight should be given per day, out of which at least 50% should be of high biological value. This will help in preventing the progression of renal disease. Multiple studies have been conducted, multiple systematic reviews, multiple randomized controlled trials. There was one meta-analysis which I won't go into details of this meta-analysis, but the conclusion of this meta-analysis which was conducted was that there was a very favorable effect of restricted dietary protein intake, that is low protein diet, LPD, and very low protein diet on metabolic surrogates of kidney function, like improvement in azotemia, improvement in bone and mineral disorders, prevention or retardation of metabolic acidosis, as well as there was slower progression of kidney function decline, and there was slower progression of CKD. Overall, this helped in preventing progression to end-stage renal disease and the need for dialysis as well as death. On the contrary, there was no significant increase in cachexia, because once we restrict the protein, we are depriving our body of essential amino acids, which are building blocks of the body. So when we restrict the protein to a certain extent and when supplement with keto analogs, there was no increased risk of protein energy wasting or cachexia, nor was there any safety issue in any of the trials which was included in this meta-analysis. So this concluded and helped this bodies and organizations to conclude that when we restrict the protein intake to either low protein diet, that is 0.5 to 0.6 grams per kg body weight per day, or even very low like 0.3 to 0.4 grams, but there have to be essential supplementation with keto analog. This will have all positive effects on CKD progression and uremia and management, as well as deferring the requirements for dialysis or even renal transplantation. If we look at the nutritional management of CKD patients in various studies and various this organization, whether it's European Renal Organization, whether it is National Kidney Foundation, whether it was KDIGO, that is Kidney Disease Improving Global Outcomes Trials, all of them have in one or the other way recommended that once you restrict the patients on proteins, that is low protein diet, you have to supplement them with keto analogs to prevent its negative impacts of wasting or cachexia. Next slide. So single strand and double strand. So most of the patients will require at least 10 to 12 tablets per day when you are supplementing with single strand to decrease the pill load on the patients and to decrease the overall burden of pills. There has been now double strand tablets which are available. This will basically reduce the pill, but despite that, there has been no improvement in benefit of this drug. Next. So overall clinical benefits of this trials was that there was lowering progression of dialysis or lowering progression of kidney disease, requirement for transplantation, requirement for peritoneal dialysis, and even death. Next. Yeah. So all of these trials, whether they were done in 2007, 2006, 2002, every year down the line, there have been multiple trials, multiple meta-analysis, multiple systemic analysis, RCTs, which have one or other way concluded that you restrict the patients with protein, that is 0.5 to 0.6 gram per kg body weight, but then supplement them with keto. This will have a positive effect on protein metabolism, positive effect in overall well-being of the patient because you are not depriving of the nutrition. At the same time, you are also providing the benefits of low protein diet by reducing the workload on the kidneys. And next. Yes. So to summarize about this keto analogs in prevention and management of chronic kidney disease patients, the most important point is selection of the patient. When to start? So the first point is to remember is when patients enters into stage 3 to stage 4, you should start this low protein diet or very low protein diet and supplement them with alpha ketoanalogue. What will happen is that this will prevent the progression. This will prevent the catabolism of the body. The cachexia and the protein energy wasting, which we frequently encounter in stage 5 CKD patients, will be prevented. At the same time, we will also prevent the progression of chronic kidney disease. So once the patient comes early, stage 3, you should usually supplement them with alpha ketonologue and slight restriction of protein. Now, again, there is some difference of the opinion in whether patient is on dialysis or patient not on dialysis. So whether patient is diabetic or patient is non-diabetic. So for non-diabetic patients, non-dialysis dependent patients, stage 3 to stage 4 and stage 5 also, you should restrict protein to 0.5 to 0.6 gram per kg body weight. If patient is compliant enough, metabolically stable, non-diabetic, and is ready for continuous regular follow-up with you, then you can even still go further with very low restriction of protein, that is 0.3 or 0.4 grams per kg body weight. But make sure that you supplement them with alpha ketonologue. The scenario is slightly different for those who are metabolically unstable, those who are diabetic, because they are metabolically very active or highly catabolic. Restriction of proteins up to 0.3 or 0.4 may not be feasible because it will worsen the anorexia, worsen the cachexia of the patient. So in those patients, usually restriction up to 0.5 gram and supplementation with alpha ketonologues will help to prevent this catabolism and has some metabolic anabolic effect on the body and may help to prevent the progression of chronic kidney disease in this CKD stage 3 to 5 patients who are metabolically active and diabetic. Otherwise, safely, it's good practice if you slightly restrict the protein and supplement with alpha ketonologue. Yeah. So I think I've made some light on this use of keto analog. What are the indications and in what group or subset of patients we can use this alpha ketonologue, thereby avoiding the contraindications and avoiding the complications of low protein diet and benefiting the patients by increasing the anabolism of the body and in preventing the progression of chronic disease. I think I'm open for any of the questions if you have.
Thank Thank you so much, sir, for a very crisp and comprehensive presentation. The first question that I would like to ask you, it's a very practical question when it comes to Indian population. Sir, you must have seen a wide variety of patients coming to you, which are either from a very protein dense diet or they are on a restricted diet. For example, the vegetarian eaters. So there are two extremes: the non-vegetarian eaters and the vegetarian eaters. So how do you manage the low protein diet in such patients? And where do you see the alpha keto analog fit in such patients?
About this vegetarian and non-vegetarian group of patients. So first we'll talk about non-vegetarian. I usually restrict the non-vegetarian food in this patient because definitely it is very high protein content and it will definitely increase the protein load in the body and as well as on the kidneys, and it will further progress the damage. So for non-vegetarians, I usually recommend to restrict completely for non-vegetarian foods, and I would supplement them alpha ketonologue so that the protein content is not, the essential amino acid content is not taken off from the diet. For vegetarian, I don't usually restrict completely the vegetarian food because if you look at the protein content or the density or the quantity of protein which they consume in the vegetarian food is very much low as compared to the non-vegetarian. So for vegetarian set of patients, protein restriction is not very strictly needed, but still, as I told in the discussion, about zero point 0.5 or zero point 0.6 grams per kg body weight. So for an average vegetarian male or female who is weighing around 60 to 70 kgs, restriction to 30 to 35 grams of protein per day from his regular meals in form of dals and pulses, and then supplement the remaining with the alpha ketonologue. I usually start with 2 tablets in a day for 3 times. That is around 6 tablets. Now, because the double strength tablets are available, so becomes slightly easier because we can decrease the pill burden. So, for vegetarian diet, restriction of protein is not very much strictly needed, but definitely for non-vegetarian, it's very strict to be restriction on that.
So is there any difference in the dosage when it comes to these kind of population, to extreme populations?
I individualize that based on the build of the patient because there are completely whole spectrum of people from males and females, from child to adults, obese, non-obese, diabetic, non-diabetic. So I usually prefer an individualized approach in each of the set of patients.
And so when it comes to the standard guidelines regarding the dosage and administration of alpha keto analog, there is also a debate regarding the dosage. So in clinical practice, what is the standard dose that you prefer and you would like to recommend the other fellow doctors as well?
So for those who are restricted on proteins, like low protein diet, that is zero point 0.5 to zero point 0.6 gram per kg day, it's recommended that for single strength tablet which are available, it's 2 tablets for 5 kgs, and for double strength, it's 1 tablet for 10 kg weight. So that usually comes roughly around 2 tablets 3 times in a day, which for an average 60 kg middle-aged adult, that would suffice.
So is there any particular biological marker before initiating the alpha keto analog therapy that you observe?
Not actually. It's mainly the muscle bulk which I look or the overall nutritional status of the patient. If you ask almost every patient of chronic kidney disease have some misconception that they have to restrict protein. So once they know that they have kidney problem, they usually completely cut off all the protein from the diet. So by the time they come to us, they are either in stage 4 CKD, completely malnourished, so a lot of muscle has already gone away from them because they self-restricted or because of physicians and general practitioners, they usually restrict the protein. So initially it is required that I need to start more drugs, more tablets, and then slowly once the will start building up, I gradually decrease it. And at the same time, I also introduce some amount of protein simultaneously so that both is taken care of.
And so when it comes to the clinical outcomes of alpha keto analog, what are the key parameters that you measure for the improvement in such patients?
One is overall general well-being. How patient is feeling after this conservative therapy, which we are doing for prevention of progression. So overall generalized well-being of the patient, whether his appetite is improved, whether his nausea and vomiting is settled down. So clinically, we usually look after this. If you ask for the laboratory parameters or biochemical parameters, then one is definitely serum albumin levels, and second would be the cholesterol level. So these two are usually a good markers to see whether patient is metabolically improving or not.
So, since a lot of physicians have also joined us today, so when it comes to the diabetic patients, what is your approach? Is there any particular caution that has to be followed in the management of CKD in the diabetic patients?
Yes. So those patients who have CKD because of underlying diabetes, they are already on a very restricted specific diet for their sugars as well as for kidney patients. And they are also metabolically very active, if you see, because it's a metabolic disorder which is underlying the chronic kidney disease. And CKD per se is a metabolically catabolic state. So they are because metabolically very active and catabolic. So usually restricting protein to a very low extent, like very VLPD, which is very low protein deficiency, is not possible in those patients. So it's always a good practice to restrict them on a low protein, so zero point 0.5 or zero point 0.6, and supplement them with alpha ketonologue. If you try to restrict to very low or almost nil, like zero point 0.2 or zero point 0.3 grams of protein per kg body weight per day, then I think we are harming more, because already a cachectic patient or catabolically active patient is again restricted more on the diet. So it's a good practice to combine low protein diet and alpha ketonologue, 2 tablets 3 times in a day. This will help to build their muscles. They will also help to keep their catabolism slightly on the lower side. And whatever urea, nitrogen which has been produced because of the protein catabolism will be taken care by the alpha ketonologues to convert into essential amino acids.
There is one last question that I would like to ask regarding the different protein powders that are available today in the market. So, how do you see alpha keto analog vis-a-vis the other protein powders that currently available for the CKD patients?
Yes. So protein powders, I think there are a long list of protein powders which are available, right from general people, for kidney patients, for liver patients, everything. So before choosing a particular protein powder, important point to think on to look is that potassium and the phosphorus content. These two are most important thing to be taken care of when you're selecting a protein powder for CKD patients. Most of them are usually having very low potassium content, and they are usually phosphorus deficient. So that is a good protein powder. You can definitely combine them with alpha ketonologues. There is no harm in combining protein powders with this ketonologues, because protein powder by and large are supplementing the proteins which you want to give through diet. If they are not taking adequate amount of protein from the diet, it is a good practice to combine this protein powders 1 or 2 scoops per day, depending on the grams of protein which each scoop provides. There are even protein biscuits which are available specifically for CKD patients. But I don't see any harm in combining this alpha ketonologue with protein powders, because it's basically the same thing, that low protein diet and the ketonologue. So low protein diet either in the form of the meals or the food, or in the form of the protein powder. That not any harm in combining both.
So, will that affect the nitrogen load in such patients where there is protein powder also given to the patients?
Not actually, because the alpha ketonologues will convert into the
Balance.
nitrogen and urea, which is generated because of the catabolism, into basically it will convert into essential amino. So they will balance the load which is going on kidneys, rather than it will help more.
Thank you so much, sir. With this, we come to an end of the session. And just for the knowledge of the audience, we will have the recorded session available on YouTube, and you can watch it any time and share your comments or any questions that you would like to share. And sir, with this, I would like to propose a vote of thanks for sharing your clinical experience and a very practical thoughts regarding the need of alpha keto analog in chronic kidney disease management. And I'm sure the doctors who have joined us today will take few insights in their clinical practice. Thank you so much, sir, for joining in. We look forward to your continued support and guidance. Thanks a lot.
Thank you. Thank you.